In one world, a patient with diabetes wakes up, scans their foot with their phone, and AI tells them pressures detected, adjust your step, no wounds form, no infection spreads, no limb loss. And then in another world, a patient ignores a callus, keeps walking, feels nothing secondary to neuropathy, and comes back 3 weeks later with a deep diabetic foot ulcer exposing tendons. So, same disease, but two different outcomes. Welcome to Utopia versus reality. So before we talk about wounds, we need to talk about the word utopia. So the word utopia, the term is coined by Thomas More in 1516. Tell me why they know this is the exact year the person came up with the word utopia, and I would like to come up with a word. But it comes from the Greek root "ou," which means no, and topos, that means place. So utopia means no place, aka like a perfect society that doesn't exist. And the meaning behind this, in medicine, we would love a I would love a medicinal utopia. Okay, a utopia for medicine for us clinicians, I would hope so, would be every disease gets caught early. Every patient gets treated equally. No delays, no complications, no preventable suffering. So, but here's the truth of the matter. Medicine doesn't fail because we don't know what to do, which is absolutely true. It fails because we can't always do it in time for everyone, everywhere around the world. So let's split this. So, first split early detection. So, in a utopia world for diabetic foot, every diabetic patient would get routine screening, smart insoles detection, detecting pressure changes. Neuropathy is caught quite early, okay? Because you know something, I feel like we shouldn't even call them diabetic foot ulcers. We should call them diabetes neglected foot ulcers because the only reason they get to that point is secondary to negligence because the neuropathy isn't detected early enough. The patient doesn't have the right shoes, the patient education is less because they're not being able to know to check their feet every day. They don't have the right insoles to offload the pressure, you know? So in a utopia world, early detection, nothing is missed. But in reality, patients don't check their feet. I think it's mostly secondary to patient education. Clinics are overloaded, yes. Neuropathy goes unnoticed, okay? And by the time they're present, the damage is already done. So, what does the research say? Up to 25% of diabetic patients will develop a diabetic foot ulcer in their lifetime. About 85% of amputations are preceded by an ulcer. And early detection programs can reduce amputations by 40 to 80%. So, that is not a small number. And that's a big difference between walking and not walking. But what is the truth? Early detection isn't just helpful, it's actually one of the most useful, powerful interventions in diabetic foot care. I'm confused why we're not doing more about it. Okay? Next, let's say the patient gets the first lesion, their first ever blister, little area of high pressure. So, in a utopia world, the patient has a small blister appears. It gets cleaned, it gets offloaded immediately, it gets monitored immediately, okay? Heals within days because it's a blister. It's just like grade one. Well, yeah, grade one. Let's do a grade one. But in reality, a blister appears, then it becomes a callus, then it breaks down, and it turns into a diabetic foot ulcer. And now the clock starts ticking. And what does the research show that most ulcers develop from repetitive pressure and shear. Neuropathy prevents the detection of us knowing that, hey, there's repetitive pressure and shear and the skin is breaking down. And the delayed care worsens the depth and severity. So many first lesions go untreated for weeks or 2 months. And to be honest, patients do listen a lot to what their physicians say. I had a patient who had ulcer for it was like this thick callus ulcer for months, and they told me that the doctor said it was okay, like, just keep it clean, whatever. It's very callous, very extremely callous, like, I would say a point 0.5 centimeter of hyperkeratotic callus tissue, and they were told that that was okay. I was like, "No, this is not okay." Why didn't they debride? They told me to just they said they will just leave it alone. I'm like, "Okay." Well, but we debrided it, now they're healed. Thank you. But so let's think about the reality of it. Global treatment versus reality. In an ideal system, patients would be able to have immediate offloading, multidisciplinary care, and regular monitoring. In reality, patients try home remedies first. That's one thing I do notice. Use of improper foot care, foot wear, and then continue working on a wound. And because they don't have a choice, because honestly, who has real free healthcare? People most of the time have to go back to work because they have to pay for these doctor's visits. They have even if they have a high deductible, they have a high copay, they still have to pay something. And if they're not working, they're not getting paid. And then on top of that, patients, the paperwork to get through disability and all like that is a lot for a patient. I it's a lot. So, next split, when it comes to infection in diabetic foot. In a utopia world, infection is identified early, treated precisely. If they need to culture if needed, okay? But there would be no spread. There would be no deep tissue involvement. But in reality, infection is usually ignored. Infections usually self-treated or misdiagnosed. It usually progresses to cellulitis, abscess, or osteomyelitis. And I the misdiagnosis irks me to the T. But infection is present in about 40 to 60% of diabetic foot ulcers, and osteomyelitis occurs into about 20% of cases, but I believe that number is significantly higher. And as we know, infection significantly increases the amputation risk. And like we said, when it comes to infection, it's like a playground when they are in a diabetic foot because they thrive so well in this environment and they have high adaptability. And the infection doesn't just appear, you know, it almost happens secondary to delayed recognition and delayed treatment, okay? And you have to also remember the patients usually come in if they have neuropathy, they come in usually because it starts causing them pain. And like I said, when a patient has neuropathy and they start feeling pain, that is not the best sign. That tells me this is something deep and this is something concerning, okay? Rarely it's something that is you can just discharge and be like off you go on your way. Okay? Usually I just usually associating it with deep abscess, osteomyelitis, possible neck fast, but or gas gangrene, okay? That's usually what I think of. We have to rule out the worst case scenario first. I like to do that, okay? Some people do because honestly, like we say, time is tissue, okay? But next is access to care. In a utopia world, patients can have immediate referral to specialists, multidisciplinary care, within days, a seamless coordination. But in reality, there are delayed referrals, limited podiatry access. We have to think about the geographic barriers, especially in places where they're resource limited and patients are bounced around between providers while the wound worsens. And honestly, another one thing that grinds my gears, that's what Peter says from Family Guy, right? Grinds my gear, is the people who are making decisions for the community of people, patients, right? And these are usually people who aren't doctors. They're business people. So they're not at the front lines of seeing what happens to these patients and understanding who's mostly the demographic or anything. They're just making these business decisions like, oh, can they afford this or not? Is that what medicine is? That is not what medicine is. That is not what medicine is. The whole point of the Hippocratic Oath is do no harm. These people who are in the business aspect of the medicine, they did not take a Hippocratic Oath. Okay? They took down the patient's bank account and took the card down and took the money. They don't care if the patient can afford it or not. They just care that the patient can pay for it. I don't like stuff like that. Okay? What matters is we do no harm and we save limbs and we clean and treat diabetic feet, okay? And prevent amputations. That's the whole point of this. But next, final outcome, amputation. That's what we're trying to prevent. Okay. But still, this number still exists. 20, they say about 20 seconds. Every 20 seconds, a limb is lost globally due to diabetes. Why is this extremely high? What is the problem? Why is this number extremely high? Secondary to our healthcare system, access, patient, education, and resources, okay? And then the 5-year mortality after a major amputation is extremely high. Many amputations are preventable, like I said. Why does this gap exist? It's not because we lack it's not because we lack knowledge. It's because of delayed detection. Okay, you gotta care. The moment they have diabetes, vascular podiatry, vascular podiatry, vascular podiatry. I have to say it 3 times so it's gonna get ingrained in people's head. Limited access, financial barriers, system failures, patient education gaps. Unless there is a program that calls a diabetic every single day and say, "Have you checked your feet today? What are your feet doing today? Is there areas of redness?" We have to do patient education, okay? Next, offloading and immobility. So in a utopia world for a diabetic foot, a patient can be placed in a CAMBU, given a mobility plan, educated on risk, and monitored closely with no complications, right? Perfect world. But in reality, a patient is placed in a CAMBU, told to stay off, can become sedentary, could possibly develop a deep vein fibrosis, and that can dislodge and become a PE, okay? And the wound improves, but the patient life is at risk. So we have to keep all these things in mind. Next is the outcomes, okay? So in our utopia world for diabetes, a diabetic foot, limbs are preserved, function is maintained, quality of life is intact. But in reality, there are patients with chronic wounds for more than a year or two. Okay, recurrent infections, amputation. These people learn to live with an open wound. Can you imagine that? Anybody who's had a scrape, they cannot stand having that wound and having it like what is it, the scab that forms, the contracture, things like that, depending on where it is. But nobody likes having a wound that doesn't heal and it just stays open. Okay? It's quite hard. And in reality, a lot of patients have to deal with that. The risk of recurrent infection and then the risk of amputation increases. And after amputation, that 5-year mortality rate rivals many cancers. Okay? But this is not just one thing problem. The gap exists, like I said, education gaps, okay? And I honestly think also education gaps in the medicine system because there are people treating diabetic feet who aren't well versed in diabetic feet, okay? It's like you ever saw that movie with the person with 12 different personalities all in one, right? And you don't know which one to call on to come out and all that jazz. That's a diabetic foot. They have multiple personalities. You gotta figure out which one it is. Got sometimes they have 2 personalities, okay? Abscess, there's osteo, okay? But there's not a one size fit all when it comes to the diabetic ulcer, okay? And then these system failures. These patients aren't getting referred fast enough. These patients have limited access. There are socioeconomic barriers, okay? Human behavior as well. The utopia falls, and that's not because we lack knowledge. It's because we fail to apply it consistently, okay? Everybody deserves a right to high quality healthcare. But is it like that? No. Okay? It's based on our socioeconomic status, unfortunately. Okay? So, when it comes to the education problem, patients are often not taught to check their feet daily. If you're diabetic, just check your feet every day. Check your feet every day. What are the early signs to look for? When to seek, okay? As a clinician, these things are often overlooked because a lot of physicians are overworked. They have a limited time when it comes to patients. Some places they only allow you a 20-minute slot, 15-minute slot, a 10-minute slot per patient, okay? And a lot of places in developing countries are under-resourced. Now, let's talk about the system. Here's what we don't talk about enough. Like we said, amputation is a failure of the healthcare system. Many decisions about patient care, like I said, are made by people who are not at the front lines of medicine. These are people who are not at the bedside, not in the clinic, not bending their back over, okay, to treat these wounds and get a scalpel and do all the right decisions. The policies are made by administrators, insurance systems, cost-driven models, okay? And this affects the patient's access, treatment options, and outcomes. So how do we fix this globally? education at scale, public health campaigns, patient self-check training, early screening programs, community clinics, mobile foot care units, okay? Actually certified ones, okay? Because I'm not for, and if that's your opinion, I'm not for anybody just running around mobily, clipping toenails and not trained. Affordable offloading, that is a big thing, okay? These patients who don't have healthcare, they have to pay for the offloading device out of pocket. And what do people do? They see the need. They see the need, their eyes go cha-ching, cha-ching, like they're Ebenezer or they're Scrooge McDuck or whatever, and they don't care if the patient gets it or not. The whole reason of offloading is to treat the wound, not to treat your wallet. Affordable offloading devices are needed for these patients, okay? And some patients can't afford it at all. Still put them in a shoe. Subsidize the care. Multidisciplinary teams, faster referrals, integrated care. I feel like we all need to stick together. We all need to know each other. We all need to have a group chat on WhatsApp, okay? Or not WhatsApp, through email, okay? And be like, I referred this patient to you, okay? That's it. I don't if it with HIPAA compliance, okay? And then policy change. Advocate for coverage for patients. Reduce financial barriers. The biggest thing is for me, I've noticed for my patients are reducing the financial barriers, okay? Because I hate hearing a patient who is sick, could possibly die, and say, I can't afford that. Why you care? Why do you care if you can afford that? We still have to fix you. We still have to treat you. But there are people, I promise you, there are people out there that who's like, oh, okay, I'm sorry you can't, off you go. There are people like that. That is not the Hippocratic Oath. That is not medicine. Okay? If they can't afford it, deal with administration, but you're still supposed to heal the patient. If they go missing afterwards, that's fine. But the whole point of being a medicine or healthcare professional is to treat the patient and help them get better, heal them, not make it worse. But in closing, utopia doesn't mean perfection. It means direction, a standard we strive towards. Because right now, we don't lose limbs because we don't know what to do. If you're diabetic specialist, limb salvage, you usually do know what to do. We lose them because we don't do it early enough, right? You don't reach the patients fast enough. The patients don't always have the resources to follow through, okay? And the gap between utopia and reality is not medicine, it's access, timing, and execution. Every time you catch something early, you're closing the gap. Utopia isn't a place, it's a standard. And every time you catch something early, educate a patient, and prevent a complication, you're collapsing the gap. I was like, you're collapsing the gap, okay, between what it is and what it should be. So, in the end, the difference between utopia and reality is not medicine, it's execution. So, this is my little Gabby series, Dr. G series, Diabetic Foot Files on our diabetic foot utopia versus reality. And take care of your feet because they take care of you.